Hello, everyone, and welcome to today's webinar for mental health professionals, Managing Barriers to Reduce Family Accommodation in Pediatric OCD. Please note this webinar is being recorded and will be available as an on-demand webinar within 24 hours. My name is Sasha Sicard, and I am the Education and Membership Manager here at ADAA. I want to thank you all for joining us today. We have a great program for you. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. You have joined the webinar as a participant and as such will be muted for the duration of the presentation. We've taken a screenshot here of an example of the attendee interface. You should see something that looks like this on your own computer desktop. You will have the opportunity to submit text questions through the Q&A feature in your attendee interface. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A at the end of the presentation. For those who purchase CE or CME credit for this webinar, you'll receive an email with a link shortly after the completion of this webinar. This link will include the webinar survey and post-test questions required to receive a CE/CME certificate. Please reach out to webinars@adaa.org if you do not receive this link, or you can email me at ssicard@adaa.org as listed on the screen. I would like to now introduce our wonderful presenters. With us today, we have Dr. Jennifer Park. Dr. Park is a licensed clinical psychologist and serves as the clinical director of Rogers Behavioral Health's San Francisco East Bay location and is an adjunct faculty member at Stanford University School of Medicine. Dr. Park is an expert in cognitive behavioral therapy and treatment of children and adults with OCD, OC spectrum disorder, and anxiety disorders. We also have Dr. Robert Sells, who is a registered psychologist working in private practice and postdoctoral fellow with the Provincial OCD Program at BC Children's Hospital, University of British Columbia. Dr. Sells' work focuses on enhancing treatment of OCD through increased understanding of individual and family needs and tailored approaches to care. Thank you both for joining us. Now we will have Dr. Park go ahead and share her screen.
Great, thank you, Sasha.
You are welcome.
Okay. All right, well, thank you so much for joining us this morning. As Sasha noted, we'll be talking about how to manage barriers to reduce family accommodation in pediatric OCD. So first, starting off is like a really brief overview of family accommodation. We're going to be starting off with the case example. The case example is a little bit lengthy, but I do would like for folks to try to keep this in mind as best as they can, because we're going to refer back to it throughout the talk. So Mark is a 14-year-old cisgender Caucasian male with emotional contamination OCD. He views his brother Ethan as contaminated and is fearful that if he touches his brother or anything that his brother has touched, then he will become his brother. He avoids going near his brother and will only speak to him from a distance. Mark has safe areas and items in the home where Ethan is not allowed to touch and utilize these items and spaces. This includes Mark's bedroom, the hallway bathroom that's next to Mark's bedroom, specific chairs, and specific areas in the living room. Mark seeks reassurance from his parents that these items and areas are clean and safe. If Mark inadvertently touches an item that belongs to Ethan or sees Ethan going too close to one of his safe items or areas, Mark will ask his parents a series of reassurance questions and have his parents repeat words and phrases to him in a specific tone. Generally, Mark's parents accommodate significantly by answering reassurance questions and separating Ethan and Mark whenever possible. For example, the parents do separate pickups and drop-offs from school so that the brothers do not have to be in the same car together. The brothers do not eat meals together. The parents instruct Ethan to stay away from Mark's safe places. Mark's mother reacts anxiously to Mark's distress, and she provides reassurance and accommodation readily. In contrast, while Mark's father also generally accommodates, but he'll also try to set limits when he's frustrated by family impairment. So for example, when he's late to work because of Mark's OCD, or if Mark's OCD starts to really impact Ethan's functioning. In these moments, Mark's father can become very angry and critical of Mark, telling him that he needs to get over OCD. When Mark starts to escalate in a response, his father introduces increasing consequences, so increasing losses of privilege. So starting off with, hey, no more TV time, then no more use of your cell phone, then maybe no screen time altogether. When Mark's OCD is not accommodated, Mark reacts aggressively by punching holes in the walls, breaking doors off hinges, physically attacking his parents, and throwing large items towards his brother. The last episode resulted in Mark running into the street yelling, "My parents are hurting me," and a 911 and a child protective services call by the neighbors. Okay, so just really briefly in regards to family accommodation. As many of you know, family accommodation is the act of a family member or loved one who enables or participates in a child's OCD rituals. However, it goes way beyond just participation. Family accommodation really covers a wide range of behaviors and life modifications. So for example, in the case example with Mark's parents have accommodated or made life modifications where now both parents have to do separate drop-offs and pickups for their kids. So they are accommodating in a very different type of way, but they are accommodating the OCD nonetheless. Family accommodation, very much like OCD rituals themselves, the function of it is that it decreases the child's OCD and related anxiety and distress. So Mark touches something of Ethan's by mistake. He starts to get very anxious and upset and asks for reassurance, and his parents say to him, "Nope, don't worry, you didn't touch that," or "Hey, wash your hands, you'll be fine," or "Just wipe it off and you'll be okay." And then Mark starts to feel better. So at the end of, so essentially, when the parent accommodates, then the child's OCD's related anxiety and distress decreases significantly. It's really important to note that family accommodation happens a lot. Whenever I meet a family who tells me that, hey, accommodation, that doesn't really happen in our home, we don't really do that. That for me is kind of a sign for further assessment to try to really kind of dig in a little deeper to see what's going on. And also important to note that this isn't just something that happens with kids, it happens with adults also. The reason why there's so much attention around family accommodation in the OCD field is because of its relationship to treatment outcomes. There's a lot of literature out there that shows us that when you decrease family accommodation, you get better treatment outcomes. So it is a treatment target for most families with OCD. Now, really quickly going through the cycle of family accommodation, this really kind of highlights the negative reinforcement cycle of family accommodation. And as I noted, it's very similar or exactly the same as the function of rituals in OCD in general, that when a child is provided accommodation, when they're feeling anxiety or distress because of their OCD, they start to then feel relief. So when Mark is accommodated by his parents, he starts to feel better and his anxiety and distress goes down. But what that does is it feeds into the cycle and pretty much confirms that this will continue to happen again and again. So when we talk about family involvement in OCD treatment, it's pretty straightforward. We always say, okay, first, we want to start off with some psychoeducation with the parents, make sure that they really understand and recognize OCD and are able to label it and identify it. Then we talk about the importance of reducing accommodation, and we come up with a plan on how to do that, how to start pulling back on the ways that the parent accommodates. We also have the parent act as a coach or a cheerleader for their child when they're practicing their ERP practices. And then finally, we have the parent really support the child by also providing rewards. So that could be points when they try to, when they engage in exposures, it could be extra screen time, whatever is rewarding for the child. Now, this all sounds really great and straightforward and clean, but we also know as clinicians that it is not very often that we get a family where it's very straightforward in this way. There are a lot of limitations to this particular approach. And there's quite a bit of evidence that shows that parents actually really struggle to reduce these accommodations. And there's a couple of reasons why. First, when accommodations start to be pulled back on, when parents start to reduce them, what they start to notice and what they start to experience is that the child may experience really, really high levels of distress. They may also experience high levels of aggression or disruptive behaviors. And in relation to these pieces, what we've also found in terms of the research, it shows that decreases in accommodation only occur when you see a decrease in these types of coercive or disruptive behaviors. So what that really means is that we do have to target the disruptive behaviors and the coercive behaviors in order to see a reduction in that accommodation. Another aspect that leads to struggles with parents reducing accommodations is parental emotions themselves. So parental anxiety and fear, maybe feelings of guilt that they're not helping their child, feeling like they cannot tolerate their child's distress or anxiety, and that increases their own anxiety and distress. There is literature that supports that when parents' distress tolerance increases, then we see better treatment outcomes. And that really highlights the need to help and support parents in being able to deal with those negative emotions that can arise when they're trying to put ERP practices in place. And finally, there's a lot of evidence out there that when you have highly critical or emotionally expressive parents, that can also lead to attenuated treatment responses. So when parents are very conflictual, very critical, and very negative, that can really damage the familial relationship, even while you're trying to reduce accommodations and support the child through OCD treatment. So there are, in terms of parental responses, two types of parental responses. First is the accommodating response. That's the one that we've been talking about quite a bit right now. Now, the accommodating response is how it starts off is very gradual, and it's something that makes a lot of sense that a lot of parents would do. It lightens the load of the child. So when a child is in distress or they're struggling, it makes sense. A parent wants to come in and say, hey, you know what? You don't need to do that. I can take care of it. Or, hey, maybe you don't need to do your chores anymore. I'll do that while you focus on this other thing. And it's natural, it's well-intended, it makes a lot of sense. But the detriment behind accommodating responses is that it will grow over time. Another aspect of the accommodating responses is that there are quite a bit of short-term benefits. Not only through accommodation do you reduce the distress of the child, but you also reduce the distress of the parent. So by providing accommodation, the child is less anxious, less upset, and then the parent in turn is also less stressed, less distressed, less anxious, and they're able to function better. Another piece is the maintenance of functioning, and that's a really important component of the short-term benefits. So again, in the context of the case example of Mark and Ethan, when you're looking at Mark and the parents have made this decision, hey, we're going to drive two different cars to school drop-off and pick up. They may have done a brief cost-benefit analysis in their minds of, hey, it's more important for us to get Mark to school than it is for us to say to him, hey, we're not going to accommodate this behavior. So in their minds, they may know, hey, going to school or not being able to go to school because we don't accommodate is too big of a cost for us to take at this time and too large of an impairment. So they want to be able to maintain their baseline level of functioning of their child, and so they will accommodate in order to do so. The problem with these responses, as we've talked about before, is that it's part of that negative reinforcement cycle. So you never really are able to break out of that cycle, and it ensures that that cycle will continue on. By accommodating, you reinforce the OCD symptoms, so basically strengthening that feedback loop. It can increase impairment. So, when a parent takes away more responsibilities from the child, then the child has less and less that they need to do or that they can do over time. And it shifts a lot of the responsibility away from the child and onto the parent themselves. Now, the other type of response is parental response is the antagonistic response. And the antagonistic response is the parent who may respond, it's the exact opposite of accommodating. So they can be much more harsh in their responses where they say, nope, I'm not going to do that. I'm not going to answer your questions. I'm not going to do this because that's your OCD. Or they might say, just stop doing that. You can control it. You have to control it. Just cut it out. One of the aspects of the antagonistic responses is that it does work in the short term. It does stop the behavior. And again, this type of response is natural and well-intended, but like the accommodating response, it can escalate and grow over time. It also has its own short-term benefits. First and foremost, it stops the behavior. A lot of the times the child stops going to that type of parent and asking for reassurance or asking for accommodations. Also, the parent and the child don't really have to address the problem at hand. When the parent says to stop, the child stops, and then they can kind of go on. Now, the big problem with this type of approach is that it does not actually stop or cure anything. The symptoms continue. And not only do the symptoms continue, it really can damage the child-family relationship or the child-parent relationship and the family relationship as well. This type of response is incredibly invalidating. And I've worked with a lot of kids who may have parents with these types of responses, and they feel a lot of anger and shame where they feel shameful about having OCD and a lot of anger about the expectation from their parents that they should be able to control something that they essentially cannot. Now, what's more typical is that most families actually engage in both types of responses. You have the polarized families, where you might have parent A who responds in a much more antagonistic fashion. So that could be maybe dad who is more antagonistic and less empathetic or validating. And then you have parent B who's much more accommodating. And we can consider that to be mom, who might be less able to tolerate their own distress and anxiety and accommodate the child much more. As I've noted before, that when you have this type of polarized parental dyad, what the child ends up doing is that they will lean much more on parent B, the accommodating parent. They'll spend a lot less time focused on parent A, and parent B ends up really taking the brunt of the caregiver sort of role for the child, and inadvertently, in a lot of times, reinforcing that cycle of accommodation. But what you also see is this vacillation in response. Now, again, thinking about that case example, what we think about Mark's father is that he would kind of go through this accommodation, impairment, and blame cycle. So he would generally accommodate Mark, answer his reassurance questions, provide separate drop-offs and pickups from school. But once the impairment grows, once it starts to really impact his functioning or his other son's functioning, he starts to become very angry. So if he becomes late to work because of Mark's OCD, he'll become angry. He'll tell Mark to just get over it, and you need to, buck up and stop acting that way, and start to yell at him. And then the other type of vacillating response, which happens quite a bit, is when both parents will try to set limits and will try to refrain from accommodation. But when a child escalates, or when a situation escalates in the home, and then perhaps the child becomes angry and destructive and starts to throw things around or break things, then the parents at the height of that negative behavior will then accommodate. That's particularly detrimental, because what we're essentially teaching the child then is that in order to get their OCD needs met, they will have to resort to that sort of really, really, really high levels of aggression or disruptive behaviors in order for their parents to accommodate. So we're basically reinforcing the wrong response in a child in that situation. And so Dr. Sellis recently authored a paper on family variations, looking at families that were affected by OCD. And so Dr. Sellis, if you want to share.
Yeah, so in particular, looking at sort of this range of variables, including symptom severity, coercive disruptive behaviors, family accommodation, family impairment, sort of being in that first column, family dynamics, things like conflict, blame, and cohesion being in that second column, parenting perspectives like distress tolerance and efficacy being in that third column, and then finally parent psychopathology rates in the last. We found that there are sort of 4 groups of families that sort of came out from this analysis. The orange group is the group that when they say we're not accommodating, they actually generally mean it. These are families where youth are very private. They're not really telling their parents about their symptoms. And so the main barrier to reducing accommodations is that there aren't really any. So the role for parents would be primarily supportive, and we're not really going to focus on them today. The green group are starting to accommodate, or they have some levels of accommodation. The symptom severity might be a little bit less, but they're surprisingly high in conflict and blame. So they're responding to this a little bit more antagonistically, or maybe they're trying out both methods and they haven't fully sort of committed to one or the other. The blue group, which represents about 25%, are sort of our big accommodating families, and in particular, ones who accommodate a lot and are very impaired, but have maintained this positive relationship. So they might be very, very willing to accommodate, or they may have sort of these strong family bonds that sort of supersede sort of the amount of impairment coming from OCD. And then finally, the group that Mark would sort of fit into the most, and the ones that we'll sort of focus the most on today, just because they're the most complex, are these families that have significant levels of accommodation, but then also have these really problematic family dynamics. Parents have a hard time tolerating the distress, perhaps in part because it's so extreme. They don't feel effective, and there's a lot of that conflict and blame going on.
Okay, so now we're going to go into common barriers in family accommodation. So we talked about parental responses, the accommodating and antagonistic parental responses, but there are many other factors to consider in terms of the OCD ecosystem and the family dynamics that are at play. For children and adolescents with OCD, of course, what you want to look at is OCD severity and the level of impairment. But beyond that, how do these children and adolescents respond when their OCD is triggered or when they're experiencing anxiety or distress? Some of these kids can respond in a much more aggressive and disruptive manner. They can also respond in a more coercive manner. And when we talk about coercive behaviors, we're talking about things like, well, you don't love me, that's why you're not helping me, or you're hurting me by not accommodating me, and utilizing that type of language. Also, what is the child's level of distress tolerance? Do they have any level of distress tolerance? Do they have a lot of it? And that will really kind of play a large part into the picture of how to approach these kids when doing OCD treatment. What's the child's level of insight? Do they know that there's an issue here, that there's a problem? And finally, what is their relationship like with their parents? Do they have a good level of trust and openness? Do they feel safe talking to them? Or do they feel unsafe? Do they feel so that they're going to be blamed or criticized when they're talking about their OCD? Other aspects to take into account are the parental factors. In terms of parents, you have their own personal history as well as their psychopathology. So what were their experiences like during their lifetime? Do they themselves experience OCD and anxiety or even depression? We know that OCD is a familial disorder, so that if you look at a family tree, it's very highly likely that you will see other types of OCD or anxiety through there. So psychopathology may be a very important aspect to look at. What is the parents' knowledge and beliefs? What do they know about OCD? How do they understand it? Do they feel as though OCD is something that can be controlled by the child? Do they think that it's something that's uncontrollable? Do they feel that a child being in distress is the worst thing possible, that it's not therapeutic or helpful? Do they feel the need to save their child whenever they're feeling bad? And what is the parent's own ability to tolerate their distress? Do they have skills to be able to help themselves? Some parents do, a lot of parents don't. And then of course, finally, what are their other relationships like? What is their relationship like with their child and within their family as well? And so we're going to do a deeper dive on some of these factors. And first, starting with the coercive and disruptive behaviors. As I just mentioned, this includes aggressive or non-compliant behaviors that are directed towards family members, and that emotional blackmail that I just described, that you don't love me or that you're hurting me. Now, in terms of the case example, Mark, what you saw was that at times he would escalate into these types of coercive and disruptive behaviors. He would throw furniture at his brother, he would attack his mother, he would scream at them and say that you're hurting me. He'd go down the street and start yelling and screaming in order to try to get what he needs in that moment. Now, these types of coercive and disruptive behaviors, they occur in at least 25% of pediatric OCD cases. And again, they are also present in adult cases. So this is not primarily just a child and adolescent feature. It is something that happens in family dynamics in general. And as I noted before, it's incredibly important to address coercive and disruptive behaviors, because by reducing these types of behaviors, you do end up being able to more successfully reduce family accommodation. And Dr. Sell will talk about it.
One other aspect is sort of the way parents automatically tend to respond to their child when they're in distress. And parents' automatic responses are going to come from their own experiences with those emotions and their parenting experiences from sort of cultural bases. But generally, parents have this sort of hardwired response when their child is in distress, that they experience distress and feel like they need to help them or fix the issue. Unfortunately, automatic responses designed on fixing sort of issues do not really work well in the context of the high emotion, because it's not going to make the emotion itself go away. And therefore, it's sort of these automatic responses not working. Well, I've tried to tell them don't worry about it, or I've tried to tell them, you know, they can do it, or they'll be fine, or help them figure out a different way to handle it. And none of that's worked. So I either have to get angry with them or I have to accommodate. And you'll often sort of hear parents say, nothing's worked, there's nothing I can do, I've tried everything. And so often it's because they're sort of relying on these surface level responses that don't tend to work for kids who are struggling with more significant difficulties. So Dr. Park's already mentioned a lot of these along the way, but the second level is, so parents may try that first initial response and the child continues to be distressed or maybe even escalates further. And then so parents are in this state where now they're experiencing more distress, they're seeing that they're not able to fix the problem for their child, and their ability to manage their emotions or the beliefs that they have about the scenario or the child are going to come into play. And so this could be beliefs like distress is harmful. If they have a negative relationship with anxiety, they may really believe that having anxiety is something that's really bad for their child. And so they're going to want to accommodate, or they're going to want to make sure that they don't have their child become anxious in the first place. They may doubt the child's ability to tolerate distress. And as a result, they may sort of feel like they need to provide that accommodation for the child to be successful, or they may even discourage the child from going into situations where they think they're going to be triggered because they think they're not going to be able to handle it and will fail. Some parents are going to doubt that the child's emotional experience is genuine. You're faking it, you're making this up, there's no way this can be that big of a deal, it's just a door handle. And a lot of this is going to then come across with parents trying to set limits where there's no way it's going to be successful, or sort of bringing in a lot of that invalidation, that blame, and those other things that damage the relationships. And then the last two are sort of generally related to each other. So parents have a hard time seeing their child in distress, and then that can sort of create their own distress, which a lot of parents may struggle with as well. And so that may result in modeling. The child is afraid, the parent becomes afraid. They're showing this fear back to their child. Or the child is afraid and demanding something, and the parent is stressed about that, and that comes out in volatility and frustration because the parent can't handle their own sort of emotional distress in that situation. Additional ones that we've sort of talked about can be that focus on short term. If I don't do this, they won't get a good night's sleep. They have a test coming up, I don't want them to do poorly. They're a high-level hockey player or soccer player, and that's really important to them, so I don't want them to miss a game or not do well. So these are going to make them less willing to sort of reduce accommodations in certain areas. Fatigue or burnout is a big one, especially in these high conflict families, and especially if there's been a big delay in terms of accessing treatment. The family members might not like each other anymore. The parents may not have energy. If the symptoms are hugely impairing, they may be struggling with stress at work because they're not meeting their responsibilities, and they just don't feel like they have the energy to set those limits or to, reduce accommodation, or they might be more likely to give in when the child escalates. Some parents might share triggers for distress with the child. So either that they share the same contamination fears and they're sort of modeling, oh, that's disgusting. Oh, I wouldn't do that either, which may be an accommodation or sort of an encouragement of some symptoms. And then on the other hand, if they've had an emotionally abusive parent, when the child tells them that they don't love them and that they're a terrible person, that may trigger a lot of distress and make parents sort of revert to some old patterns and behaviors to avoid or to sort of get out of that situation. And then a final one we see a lot is just parents who are struggling with just their own emotions about the situation. Did I cause this OCD to happen? Is it my fault? Am I a bad parent? What's going to happen to my child down the road? And while you might think, okay, they're thinking about the future, that's a good thing. If they're too worried about that, they may end up sort of being focused more on relieving that emotional distress rather than trying to make those long-term parenting choices.
All right, and so just going back to our case example, this is a really brief sort of case conceptualization of just thinking about how Mark is presenting and the barriers that we've introduced and talked about. And like I said, it's very rough and we can probably get this to be much more extensive, but real focus on the accommodation behaviors. What are the identified accommodation behaviors? What are the coercive and disruptive behaviors that we were able to identify? And what are the parental emotional management issues that we also want to be able to target? So we kind of broke them down and was able to identify these pieces. And this will really help guide us in terms of identifying interventions to be able to develop Mark's particular treatment plan. So that takes us into interventions for barriers.
So if we come back to the model of family involvement in OCD treatment, it's helpful to think about it instead of just this small piece as something that's really happening parallel to everything that the child is doing. That every goal that you have for the child, you also have for the parents in terms of how they relate to the child's symptoms. Because, like we talked about, accommodation serves the same function as rituals. So effectively, parents are part of the OCD. They are impacted in the same way that the child is. They are drawn in the same way that the child is. So understanding the disorder, its cycles, and how they play a part. Normalizing the symptoms of what the child experiences as well as their responses to it, and letting them know they responded in ways that generally make sense or that most parents would. Helping them identify what the long-term goals are. Doing well in school, okay, that might be one, so how do we sort of think about that as a broader goal? Sort of diving into some of these emotions and beliefs that they have and how they play in. Helping them shift their responses towards the ones that have a long-term impact, building their tolerance of distress, building their confidence to manage that distress, even if there's big emotional outbursts, building their efficacy to cope, other supports for their well-being, and helping them figure out, okay, what's OCD and what is a typical teenage behavior or ADHD or other things that might be going on. So the first step that you might be taking sort of after psychoed and these other sort of initial things is helping parents build their awareness of what's going on. So what are some of those typical automatic responses that they have to emotions or distress? After those typical responses, what are some of the ways that they're trying to provide support that may be problematic? So accommodations, both the direct ones as well as sort of these indirect ones that they might be doing without the child requesting it, just to make life easier, as well as the conflict and the antagonistic responses. At the same time, you also want to help parents figure out whether it's related to OCD or just in general, the positive supports and things that they do for their child. In what ways do they connect to their child well? Do they help their child feel better or be successful? how are there any reinforcement systems that they have in place in the home that could be sort of utilized or shifted to work well towards fighting back against OCD? Are there any places where they have clear house rules or limits that work well that aren't related to distress or OCD that we can sort of think about utilizing for OCD as well? And then another step is going to be sort of making them sort of focus on that cognitive and an emotional piece. What are their beliefs about the distress, about the symptoms, about parenting? What are their emotional experiences? And are there specific emotions that are hard for them to tolerate or reasons why they're hard to tolerate? One way to do that, and this comes from the unified protocol, is to essentially do functional analysis, have the parents do that both for the child's behavior as an empathy building exercise to help them understand what exactly the child is going through, what triggers are happening, what emotions, thoughts, and behaviors, and then what the short and long-term consequences of that are. But then to have them do the second step of analyzing their own experience in the moment. What were their triggers? Oh, I was really tired that day and stressed out because I had a busy work meeting the next day. What were their emotions? Yeah, stressed, exhausted, thoughts, not this again. I don't want to go through this again. Can we please just get this over with? And then sort of how did that influence their behaviors and what are those short and long-term consequences? If we help parents realize that these sort of cycles interact with each other, we can empower them to realize they can make change by sort of stopping their wheel in the cog versus sort of having them always focused on changing the child. So I'm going to outline just a couple key principles that are helpful for parents. You may not need every principle for every parent, but in general, they're helpful frameworks to think about managing accommodation in a more sort of sensitive way than just accommodation bad. So the first one is some parents are going to say, well, I need to know, do you not accommodate at all, or do you always accommodate, or what exactly do I say when they ask for reassurance? Helping them shift away from that sort of single idea model to just being a present and intentional parent, being mindful and there with their kid. A lot of parents are going to be focused on, how do I make my kid feel better? How do I solve the problem? And you want to help them shift towards thinking about, how do I get my kid better at feeling? And by that, tolerating distress rather than escaping from it. They're going to be thinking about getting that good night's sleep. How do you shift from that? I skipped one. So the short-term consequences to those more long-term things. How do you help them improve their sleep over the next 5 years rather than one single night? How do you help them shift from feeling like they have to stop their child from washing their hands or make sure their child isn't distressed, to managing and focusing on their own distress in those moments and the things that they do? Finally, the last three are sort of things that they can remember that are helpful. The child is going to probably show bigger emotions when you try new responses, because you're maybe allowing space for them, or you're not sort of reducing them immediately like you used to. The emotions that you display as the parent are going to be mirrored back. If you respond with fear to your child's fear, they're going to be like, oh, this is really dangerous, and that's going to amplify. And if you respond with anger to their fear, that's also likely going to draw out defensiveness and anger in them. And then finally, that parents, a lot of these parents have become so focused on just trying to help the child survive, they have completely abandoned self-care or any sort of things for themselves. And that fatigue and burnout really contributes to them not being effective. So putting an emphasis on parents taking care of themselves is also essential. So in starting to respond differently, parents can think about having an effective parental presence, one that is warm and calm, so they're not reactive to the different types of emotions, whether it's anxiety or anger. That doesn't mean necessarily robot-esque, but because you still want to maintain the relationship and the sense of trust. So there's warmth there, but it's enough to cool anxiety or cool the anger. But at the same time, parents need to be strong. They're not just doting on their child, everything's going to be okay. They have to be able to withstand the anger and anxiety that's coming towards them And they have to demonstrate a level of authority in the sense that, like, I'm going to help you get through this. You don't need the things that you're demanding of me because we can get through this together. Once parents sort of, if they take that mindset, then another thing that can be helpful is to decrease those automatic responses and give them time to find something that might work. You want to help them slow down. So if you go back to that sort of before that antecedents, thinking through the situation, parents have thought about their child's experience at this point. And in the moment, sort of thinking, what does my child really want from me? What is my child experiencing that right now? What is their distress? And then reflecting that back to the child and providing some validation. Mark, I can understand that you may be feeling really, really anxious right now and really afraid because you don't know if you touched something that your brother touched, and because you feel like that might turn you into your brother, and because you really don't want that to happen because you like yourself and you want to stay how you are. And just spending some time being there with the emotion and sort of saying, I hear you, I am here with you. Once parents can do that, if you can go to the next slide, you are sort of building this bridge to the child that may create more opportunity to put in supports that could be effective. And these could be emotional supports, which could be a hug, staying with them, saying, I hear you, this is really hard, emphasizing their ability to cope. I know you can get through this. I know you can do it. It could be backing away. Okay, I'm going to give you some space because this is really hard, and I'll come back and check in on you in 5 minutes. And it might be assurance, not reassurance, but something like, with Mark, it might be something like, I don't really believe that that would happen. It's not going to happen. You won't turn into your brother. That doesn't make any sense. It's not going to happen. But one sort of strong, supportive statement, and then moving on. There may also be practical supports. Next slide. And this could be things like helping the child redirect from the compulsion that they feel like they need to do to some sort of other activity. It may be saying, hey, let's go take a walk together, or let's go, do this coping strategy that you've previously taught the child in therapy. Having the parent do that with the child might be a way to support. Might now be having the parent help problem solve. Or this might be the time, now that you've done the validation and you've spent the time with the child, setting that limit. No, I am not going to provide you with reassurance right now. That's not going to happen. Sometimes, if it is going to help the child approach a situation instead of avoid it completely, there may be room for partial accommodation, and we'll talk about the systems for that. And then finally, reinforcing the child's coping. I'm so proud of you right now. I know this is really hard, can be really valuable.
Okay, so in terms of treatment planning with parents and thinking about how to utilize the different sort of ways of supportive ways that the parents can then bring to the table with their child, it's important to work with the parent and the child to come up with a clear plan of how accommodations will be reduced or set over time. And this is obviously done with the therapist as well. Now, it would be best if the child was involved in this process, but we do understand that sometimes they cannot be, or they are unwilling to be. But if we are able to have this, it's important to develop this clear plan and then even think about ways to problem solve challenges and prepare for difficult reactions. Okay, well, when Mark reacts in this way, how are we going to approach it? When we reduce accommodations, there's screaming and yelling and it lasts for hours, or he starts to become really aggressive and violent. How do we deal with that? So these are things that need to be addressed in terms of the plan. And as I noted, you want the child to be collaboratively involved because you want them to know what's going to happen. But if they're not willing, then parents can utilize a written letter and they can provide that information to the child so that hopefully that can minimize any types of opportunity for coercive or disruptive behaviors. It's really important not to leave a child in the dark in this process. If they don't know what's going on, the likelihood of success starts to diminish. Even if they're not a willing participant, just them knowing that this is going to be happening is really important and can be beneficial. It's also important for parents to note that they want to be very focused on the types of accommodation they're reducing. They don't want to try to reduce everything all at once. With the idea being that if you try to solve for everything, you will end up solving nothing. It's going to be too much. So it's really important to be able, for parents to be able to identify, okay, this is a moment in which we're really going to focus on reducing our accommodations, and these other moments, we're going to let those slide. We also want parents to follow through with differential reinforcement. This is whether or not a child is involved. So that reinforcement, that positive praise or rewards, it's really necessary even if the child is not actively involved in that sort of collaborative planning process. Also, parents also want to be able to follow through with logical or natural consequences. So, you know, in the context of Mark, if Mark is saying, well, I can't be in the same car as my brother and if I do, then I can't go to school. Well, a natural consequence of not accommodating would be, okay, then you're not going to go to school today, or you're not going to go to soccer practice or hockey practice today. But as part of this treatment planning process, with some of the children and adolescents that we work with, they can be, as we talked about, aggressive, disruptive, violent in the home when they are not being accommodated. And in these cases, as part of the treatment plan, it's very important to create a safety plan. Safety comes first in all aspects. Safety comes before the step of reducing accommodations. But let's say that parents have tried to reduce some accommodations and the child starts to become aggressive and physical. So first and foremost, we want to place others in the home in a safe area. So again, in the context of Mark and Ethan, Ethan would be somebody that we would have to ensure is safe. So that could be that one parent stays with Mark, the other parent takes Ethan and brings him into a different room, maybe on the other side of the home. Maybe they go for a walk. Maybe they go into the car and take a drive, if any of those things are possible. Another thing for parents to do, and it would be important to do beforehand, is to develop a list of support systems to call for help when necessary. So that could be other family members or other friends that can come over and support them when things start to really escalate and appear to get to a point where they might not be able to manage. And then the parents can also create a list of phone numbers to call. So they can call the county for some support. They can call 911. And in those cases, really encouraging parents to note that if they cannot keep themselves safe and they cannot keep their child safe, that it is important to be able to call for outside help. Next, we really want to be able to remove any type of dangerous objects from the room or move the child to a safer room. So if the child is in the kitchen and there's a lot of knives and a lot of chairs that they can throw around or grab, it would really be helpful to be able to move the child to a different room, such as a bedroom. It's important for the parent to also be able to refrain from any types of disciplining or threats during these types of moments, because when you start to escalate the consequences that may occur because of their disruptive behaviors, the conflict itself will continue to escalate, and it can really get much bigger than it needs to be. So it's important for parents to be able to refrain from that and be able to really provide a space where they can disengage emotionally so that they're able to tolerate their own stress, that they're able to stay calm and quiet, no matter how anxious or distressed that they might be feeling in that moment. Like Dr. Sellis was talking about, that this modeling behavior really becomes important, where if the parent models anger, upset, fear, then the child oftentimes will also model the same and their emotions will increase. Also, for parents, it would be important to kind of take a more of a non-confrontational stance. And so standing to the side and providing the child space when they're in those more heightened moments, heightened and agitated moments. But as part of ensuring safety, we can also create a behavioral modification plan. And this behavioral modification plan is really utilized to identify when is the appropriate time to provide accommodation. So as Dr. Sellis noted, he noted that sometimes partial accommodation is something that we do want to give in order to provide sort of an approach towards reducing accommodation. So we don't have to have this clean, no accommodation at all, but we can do this sort of halfway approach. And by doing this, we want to be able to reinforce these approximations. So with Mark, if he's in the kitchen and he wants his parents to provide him reassurance and to engage in rituals with him, and he's starting to escalate and you're feeling fearful because there are knives in the kitchen, there are a lot of objects for him to grab and throw, the parent can then remove themselves and walk over to his bedroom and say to him, hey, come into this bedroom and I will provide you the accommodation. I'll answer your question or I'll do the ritual with you. So what you've been able to do successfully is move the child away from a more dangerous environment, put them in an environment that's a little bit safer, and then provide them that accommodation that they are seeking. And that is, one step towards success. That is not something that we would identify and say, well, that was something that shouldn't have happened. It's like, no, we were able to safeguard him, safeguard his brother and his family members. And we were able to get him into a good place. And then we provided that accommodation. Then from that place, the parents can then start to work on gradually reducing accommodations from there. And it starts for patients who have a particularly hard time with the reductions in accommodations. It'll start off with delaying in providing the accommodation. You can delay it for a couple of minutes. If a child can't tolerate that, you can even just count to 10 and then provide the accommodation. You can also reduce parts of the ritual. So if a ritual is very complicated that has multiple questions and taps, can we remove the taps and then only do the questions? Again, it's that partial approach and that approximation that we're trying to work towards that will eventually get us to the reduction in accommodations that we want to see.
So I'm going to go over this stuff quite quickly, and this is sort of where we're getting into supplements. So how else can you support families more generally? So one is going to be parental self-care and then direct intervention with the parent. So talking about how they're coping, what their triggers are, providing them with mindfulness strategies to be more present and able to cope in the moment, helping them examine their problematic beliefs, whether it's about self-blame or about distress, and working through those, and helping them identify support networks, whether it's with their spouse, better communication and taking turns when the child's upset, those broader networks, or accessing therapy for their own psychopathology. Another thing that you might be working on is beyond the moments in which parents are trying to model being warm and calm and strong, you're helping them help the child understand their emotional experience more by doing emotion modeling themselves. I'm feeling anxious today because I have a big work project tomorrow. It's okay that I'm feeling anxious. And it makes sense because of sort of the demands that I have on me. I'm going to take some time tonight to do a puzzle in order to sit with that so that I feel ready to go to work tomorrow. And just having them build in these conversations that will help the child or teen understand how to cope more effectively with emotions instead of defaulting to compulsions or other strategies. This is something that I've developed, and it could be primarily a clinician tool. Or with sort of more well-informed parents could work as something that you're working through with them. And essentially it would be helping them figure out different ways to respond based on the challenges that they're having and their values for themselves as parents, how they want to parent, for their values for their child, what their long-term goals are and ways that they want to grow, as well as what the child's values are for themselves. So for example, sometimes the child is motivated to work on one symptom area but the parents don't buy in as much. And so that would sort of fit in that consider and collaborate way. How can you have parents realize that if they buy into what the child wants to work on, they may get to working on what they want to work on faster? Model and inspire might be one of those ones where the child doesn't really feel like they should change something or manage their emotions more effectively. So having parents model emotion management, and then when parents try to get the child to use that strategy, the child might be more willing because they see how it works for the parent. And then pivot and support might be those ones where parents are doing that accommodation to make sure that they get along with the child. And how can they think about being supportive still in a way, providing that validation perhaps, but also having that long-term focus for their child and helping them do well. So this might be helpful if you're trying to figure out which sort of way you want to go with the family, or have the family think about that for themselves. And in the center is things that work, things that already work, and how can you do more of that? Have fun time with the child, spend time building the relationship, positive reinforcement, things like that. So this is a helpful summary slide, I think, in particular, maybe just for people's notes. I won't go over it because we've talked essentially about all of these things, but it just helps you think about maybe the way parents might be thinking about things coming in, or the way that they feel like they need to approach things, and then sort of the subtle shift that they could make that still is going to have long-term benefits without sort of contributing to the reinforcing cycle of OCD or the deterioration of the family dynamics.
All right, so just a very fast summary of what we discussed. Family accommodation, we noted it occurs in most families. It is developed and maintained through negative reinforcement. And it is an important aspect of the treatment plan, as family accommodation is a predictor of treatment outcome. But it's also important to note that family accommodation is only one part of the dynamic that's relevant to OCD treatment. There's a lot of other factors to consider and address. And what we discussed was that treatment should also target these types of important factors, especially when there's something like coercive or disruptive behaviors that are in play, or difficulties with parental emotion management. And the final takeaway is that family accommodation reduction does not need to occur no matter what. We can use the approach matter of focus. We really want to be able to ensure safety. And so it's important for clinicians to use their judgment depending on the situation on how to manage accommodation. And I think that's it for.
Right. Thanks so much, guys. Let me just quickly pop over. We have a few minutes for some questions. Let me make sure we're seeing my correct screen. There we go. Okay. We had one question while you guys were presenting. It touched upon how do you help kids with OCD about COVID?
Yeah, so what we've found with COVID is that there are some aspects of OCD treatment that we have had to pull back on. So the stuff that was really kind of our bread and butter in the past of going out into the grocery store and then licking your hands, or then eating food without washing your hands, those kinds of things, we don't do that anymore, those types of public exposures. But what we found is that we can actually do a lot of OCD related exposures even in the context of COVID, because it's about what's going above and beyond. We've had folks who, when you come home after being out, you wash your hands for 20 seconds. And then that's kind of it. That's what we want to see according to CDC guidelines. However, we see folks with OCD who come back home and maybe they'll wash their hands for 5 minutes, or they'll wash their hands and then, touch something in the kitchen, go back into the bathroom and wash their hands again. So just like anything else, we look at things that are above the norm, that's excessive, that we want to target. that we say, hey, you know what, this really is not going to put you at risk for COVID. For example, we had one girl who had trouble going into her backyard and touching her plants and then coming back inside without washing her hands. The likelihood of any type of COVID exposure, because she's in a very kind of isolated area, is extremely low. So in a situation like that, we could really, focus on reducing the rituals with that particular behavior.
Mm-hmm. Thank you, Dr. Park. We also got another question that says, we're noticing a sharp increase in OCD referrals during COVID. Is there any current research about the correlation in our prevalence across the past year?
I've seen a couple papers, and so far it's a little bit mixed. The initial sort of outcomes were that actually potentially it was going down, although I think that was primarily related to the fact that people were being more isolated and at home. So they were sort of being forced to avoid a lot of triggering situations. And I think now that we've returned more to a situation where there's a higher level of threat in terms of COVID, and people are back sort of within their communities, that it will likely see the research suggesting somewhat higher levels. From a stress diathesis model of sort of mental health sort of symptoms coming on, COVID's a stressful time. We know that it tends to emerge at similar ages, but triggered by experiences of stress. So whether it's the isolation of being at home, or family conflict within the home, or anxiety in general that's now being sort of created around a ritual, you may see sort of an emergence of COVID specific symptoms coming up, but likely even just general OCD sort of increasing because kids are in a state of more distress and are using compulsions to have control, or to reduce their emotions, or to feel better, and getting caught up in those patterns.
Great, thank you so much. I want to thank our presenters. We can also email you any additional questions. Attendees, do you have any additional questions? You can email me, sthecard@adaa.org, or webinars@adaa.org. I would like to take this moment to invite you all to our next upcoming webinar, Suicide and Suicide Prevention, Ethical and Legal Perspectives, that occurs on February 11th. We would also like to invite you for our very exciting 2021 Anxiety and Depression Conference on March 18th through 19th. Admission includes access to all live sessions, live Q&As, posters, and exhibits, and the opportunity to earn more than 100 or CE or CME eligible sessions. You can learn more at adaa.org and register today. And if you are not yet an ADAA member, we invite you to view the many membership benefits, including year-long access to free CEs, access to our special interest groups, including online peer consultations, significant discounts to the annual conference, listing your clinical trials on the website, and much, much more. You can visit adaa.org to learn more, or email me at sthecard@adaa.org. On behalf of our presenters and ADAA, I'd like to thank you all so much for coming and attending. Again, if you have any questions further, you can email me at webinars@adaa.org. Thank you so much and have a wonderful day.